Greetings everyone and welcome to the 38th session of the online Optom learning series. Let me introduce to you our speaker for today. Today we have Professor Bruce Moore, and Professor Bruce does not need any introduction, but I mean he's a clinical expert in terms of pediatric optometry, and he has been with us from the very beginning in this series. He has done about 3 sessions, and today he has been kind enough to do one more session on the additional refractive error management for complicated cases. He has about 45 years of clinical experience in managing pediatric population, and we do have his previous sessions recorded. So people who have just joined our series, we would appreciate that you could go back and view those sessions to get the basic idea. I'm sure that he's going to brush up to some points on today for you to get the hang of it, but it was highly recommended that you go and watch his series or videos which are on our platform. So welcome, Prof, again to our platform, and thank you very much for taking out this time and attending us again.
Well, thank you very much, and welcome to everyone. It's really a pleasure for me to have this opportunity to speak with all of you again, give some clinical pearls about the management of refractive error in children. Today, I'm going to concentrate a little bit more about the relationship between refraction and amblyopia and strabismus. So there we go. First, I'd like to just make clear that I have gotten financial support on a lot of my work over many years from the United States National Eye Institute, National Institutes of Health, that have been funding our vision and preschoolers study that has been going on now for almost 25 years. In addition, I also act as a consultant to the Welsh Allen Corporation, now part of Hill-Rom, and they, as many of you know, make ophthalmoscopes and retinoscopes, and also the spot vision screener, and I have been a consultant to them on some of those technologies that are existing and in development, so I acknowledge that. I'm just going to sort of repeat a few things that I've mentioned before. My sort of philosophy of correcting refractive error is actually pretty simple. We tend to sometimes make this very complicated, and especially for students and for people who are relatively new at refraction, it's easy to get confused about all of the various techniques and approaches to refraction, and it can be a very, very confusing experience, particularly when things get a little bit complicated. For me, in order to provide correction for refractive error, I need to do 3 things, or at least one of 3 things. That correction needs to either improve vision, or improve binocularity, or improve visual functioning. I think it's nice and simple. If you can't justify giving a pair of glasses or contact lenses based upon those 3 very basic concepts, then I think refractive correction is not necessary for that patient. Now, this one simple sentence of just less than 10 words, I think summarizes everything that I believe in. When I provide correction, I want to put a focused image 360 degrees in front of both eyes simultaneously. It's a nice way of saying I want a focused image on both retinas. If the image is not completely focused, taking into account the issue of anisometropia, taking into account the issue of astigmatism, then you are not putting a clear image there for the rest of the visual system to be able to deal with. And very simply, if you don't have clear images on both retinas, you haven't done your job as far as I'm concerned. So there are some important considerations that I think are somewhat basic. Emmetropization, when we talk about children, is really a critical element things change, and they change early and they change late. And you could think of the decrease in hyperopia in infants that typically occurs as being one component. You could think about the changeability of astigmatism in the first several years of life as another. But I think you can also think about myopia development in kids from 5 to 25, 35, 55 years of age as being part of that process as well. And even in older people, changes in the structure of the crystalline lens, leading to some increase in hyperopia in some cases. So things change, and that's important to always keep into mind. This is not a static situation. Today especially, I'm going to be emphasizing an important relationship between significant refractive error, strabismus, and amblyopia. It's really integral as to what I'm going to talk about today. And I think many of us really recognize, all of us really recognize, a relationship between refractive correction and visual function beyond visual acuity alone. So as optometrists, we tend to really think about visual function. Ophthalmology tends to be thinking less about that and thinking more about visual acuity only. But we take a broader approach to vision. And finally, the issue of binocular balance, and that has to do, in my view, with ensuring that any difference in refractive error, any spherical difference between eyes, is accurately reflected in the correction. In other words, if you have an isometropia, don't change the difference between the two eyes in your final correction. All right, so what we're going to talk about today is the issue of managing amblyopia. I'm going to talk not about deprivation amblyopia, which is caused by congenital cataract or mediopacity present at birth or very, very soon afterwards. That's far more complicated. Treatment of congenital cataracts is a big subject in and of itself, beyond the scope of our discussion today. Strabismic amblyopia is, in terms of natural history, the development of amblyopia, generally the next thing that happens after deprivation. So an infant becomes strabismic, more typically a constant esotropia, one eye always turned in. That eye is going to develop amblyopia quickly and deeply, and the treatment of that is complex. I'm not going to talk too much about that today. That's also pretty much a special topic, and maybe we'll get into that at some other point. We are going to spend more time talking about refractive amblyopia, and there are the three major categories: an isometropic amblyopia, essentially a difference in sphere or sill between eyes; meridional amblyopia, present when you have a large amount of astigmatism; and isoametropic amblyopia, when you have very high refractive error, typically hyperopic, but under some circumstances myopic as well. And the prescription refractive error is pretty much the same, but the effect of it is a deeper form of amblyopia than the other types of refractive amblyopias. It actually has characteristics that are more similar in many neurodevelopmental ways as deprivation amblyopia. So we'll talk a lot about refractive amblyopia. We'll also talk about managing strabismus in terms of refractive correction. Accommodative esotropia, the most common type. Non-accommodative esotropia, where refraction still plays a role. Divergence excess exotropia, we'll talk about. Convergence, should be convergence insufficiency exotropia, should be the last one. That excess shouldn't be there, it should be convergence insufficiency. I'm not really going to talk about that. That's a different topic, and I think it's actually been talked about pretty extensively in prior discussions by other lecturers. So let's just dive straight in. Let's first talk about probably the most common type of amblyopia and strabismus that refractive error plays a major role in, and that is accommodative. So we have a 3-year-old child with presenting with intermittent esotropia over just the last few days or few weeks. And here's 3 different scenarios that I'm going to give you. We'll discuss them together. The first one, the refractive error is the same in both eyes. So you've got a moderate degree of hyperopia, minimal degree of astigmatism, refraction's pretty much the same in both eyes. The very typical scenario here is child about 2 or 3 years of age gets up one morning, child has a fever, child's got a cold, and the child's system and general degree of health is down. It's not normal. So what happens under those circumstances? Because of the underlying hyperopia that was kept in control by the accommodative system, now because the child is under the weather, the system is not maximally performing, child wakes up with a strabismus. I cannot tell you how many times I have seen that scenario happen. Probably the most common presentation. Mom brings a child in, she's nervous, she saw the eyes cross, she knows it's not good. She got an appointment, she waited a few days to come in, and during that period of time, child got a little bit better, strabismus went away, except maybe later in the day when the child is really tired or hungry or crying, and all of a sudden, briefly, or maybe not so briefly, strabismus exists again in one or the other eye. So that's a very common presentation. The second scenario, where there is unequal refractive error, unequal degrees of hyperopia, but the eyes are still relatively straight, occasionally turning, is different, but not all that different. In this case, it's less likely to be an alternating type of crossing, more likely to be just the right eye that's crossing. And in the last situation where the eye now is crossing pretty constantly at near, but not so much at distance with unequal refractive error. So what do we do in these situations? Well, if we do dry retinoscopy, we're almost certainly going to find less hyperopia and maybe minimal hyperopia. If we do wet retinoscopy, cycloplegic retinoscopy, we're going to find more plus. And under those circumstances where there is a history of the binocular system beginning to break down, or perhaps it has now become fairly constant, or it has become fairly constant at near and not so much at distance, we're going to need to do something about it in terms of refractive correction. And we discussed these cases before, so I'll just mention at this point, what we would do would be to provide most, some would argue provide all of the refractive correction. In other words, push the plus. Some would back off a little bit. Some would maybe cut the amount of plus by a half diopter or so in each eye to increase the acceptance of the new glasses by the child. And you certainly could do either one of those approaches. And based upon your experience, based upon what you see with that individual patient, you'll make a determination. Now, for the beginning student, they need a little bit more guidance of what to do. So under those circumstances, I probably initially would cut the plus by about a half diopter, cut it symmetrically. You're going to decrease it in one eye, you decrease the exact same amount in the other eye. So again, you're putting a focused image 360 on both eyes simultaneously. Would you provide the small degree of SIL or not? Again, people might argue that. Some would say 3/4 of diopter is pretty insignificant. Why bother? I probably would do it under most circumstances. So I would provide the correction. Others might decide not to. Certainly, if there's more astigmatism than that, if there's a diopter, diopter and a half, 2 diopters, absolutely would give the correction for the astigmatism. But in a low degree, half diopter, maybe I wouldn't. It's not easy always to give hard and fast directions. It depends a lot on the situation. But I don't think there's any question at all that you would be providing correction, and you would be providing most, if not all, of the plus. What would you then do on follow-up? You'd see the child back within a month, maybe a little more, a little less, depending. At this point, you would not do any patching, even if there was a constant strabismus. You would put the correction in the form of glasses on alone. You will remember that I spoke previously and said that the number one, first, most important treatment for amblyopia is always put the proper refractive correction on before you start doing any active forms of treatment. In other words, before you start patching, you put the glasses on and you see what happens. Now, you have a 3-year-old child in this case. You may or may not be able to get accurate quantitative measures of visual acuity. So in the US, we use either Lea symbols or HOTV letters. Many of you use others, tumbling E, or perhaps other kinds of charts. If you can get a quantitative assessment, well, that helps to guide you. If you can't get a quantitative assessment, then you have to go with a qualitative assessment. And a qualitative assessment is essentially covering one eye, covering the other eye, doing it slowly, seeing if there is an objection to covering. So if you cover this eye and the child does this, you got a pretty good indication that this eye is an amblyopic eye. Child doesn't like the patch in front of the good eye. So the child's going to try to either knock it away or turn the head away like that. So that gives you a qualitative assessment, which is really all you need to know at this point in time. For a 3-year-old, you want to try to begin teaching a child how to do quantitative assessment. So you might give the parent a reduced set of whatever the acuity chart is that you're using to take home and actually practice either as a matching or naming test with the child over the next month or so. That, I think, is very good advice to do. You have the child come back and you see if the child is now wearing the glasses, the eyes are straight, well, you pretty much know that you did a good job. You took care of the problem before it became a bigger problem. In other words, you had some signs and symptoms of a problem. You were able to interject yourself into stopping and mitigating that problem. And in fact, you ended up doing a good job. Now, if there's now more crossing happening, particularly when the glasses are not on, that's very typical. So you'll often see that the glasses will control the situation with them on, but with them off, the child is now beginning to depend upon that relaxation of accommodation. And as a result, child takes the glasses off, you may actually see more crossing. You're going to have to explain to the parent how this is one of the things to be expected. It isn't an indication that things have gotten worse. It is, in fact, an indication that your treatment is doing a good job, and it makes it even more important to keep those glasses on. So this is the first type of situation, scenario one, probably the single most common, where refractive correction plays an absolutely critical role in controlling both the strabismus and the amblyopia. And we probably see more accommodative esotropia than any other type of strabismus and any other type of amblyopia. All right, let's change things a little bit now. Let's make it a little bit more complicated. There's a 5-year-old child with Down syndrome. The child is experiencing some intermittent strabismus. Parents are noticing it. Child is perhaps rubbing eyes quite a bit. Now, as you know, in many children with Down syndrome, many adults with Down syndrome, there are a host of vision problems that go beyond what we're talking about here. There are things like cataracts. There are about 5 or 6 different types of lens opacities that are extremely common in children with Down syndrome. Some are progressive, some are not. So that's something you need to keep a watch on throughout that individual's life. Have to keep looking to make sure that the cataracts are not impairing visual function beyond the other issues that are going on. You know that blepharitis and conjunctivitis are very, very common. And the reason for that is that the oil glands throughout the body, on the skin in particular, and the sebaceous glands in and around the eye and the lids that produce the oily secretions and tend to become impacted with material and cause chalazion, hordeolum, a sty, blepharitis. Those are very, very, very common findings. You probably see that in a majority of kids with Down syndrome. Now, what happens with chronic blepharitis, chronic conjunctivitis, is that often it's related to Staphylococcus bacteria. Staph bacteria give off an exotoxin, secretions that are part of the metabolic waste products of the bacteria. Those secretions, those metabolic waste products get into the tear film, cause irritation, cause corneal pitting, corneal erosions. They cause a lot of itching and scratching and burning and tearing. These kids rub eyes a whole lot. One of the most common things you see is blepharitis, conjunctivitis, and eye rubbing. And we now know that chronic eye rubbing over a long period of time causes another critically important vision problem, which is keratoconus. So one of the reasons why there is a very high incidence of keratoconus in individuals with Down syndrome is because of the eye rubbing brought on by the chronic infectious process going on in and around the eyes. So it becomes important for us to do something about that chronic blepharitis. We need to do a lot of hygiene issues. For more severe cases, you can use on a short-term basis a combination antibiotic and steroid if you're in a position to do that. Long-term use of a steroid, however, can cause all kinds of other problems, including cataracts and glaucoma. And I've seen individuals who've been on combination steroid antibiotic ointments for years that have developed both cataracts and glaucoma as a result of that. So that's just something to keep in mind. The other problems are refractive error tends to be very high. There may be high myopia, there may be high hyperopia, there often is high astigmatism. Why is that? Why are high refractive errors so common? Well, it gets back to embryology and histology. And it gets back to the fact that the process of emmetropization is impaired as part of the syndrome of Down syndrome. So emmetropization is impaired. As a result, there's a tendency to have high refractive errors. They are extremely common. You almost have to assume that every single individual with Down syndrome has a refractive problem until proven otherwise. If you have high refractive error, you naturally have a much higher risk of developing amblyopia and strabismus. So all of these things go together. These are not isolated conditions. These are highly related. So what you then need to do is you then need to do a thorough examination. Now, doing a good refraction, doing a good examination of some children with Down syndrome is obviously difficult. They don't necessarily sit still. They're afraid of what is happening to them. All of that is going on. So doing the examination can be very difficult. Obviously, it's impossible to get one of these kids behind a phoropter. So you're using trial lenses. You're using objective techniques of refraction. You cannot depend upon doing a subjective refraction and getting good, reliable visual acuity results. You have to use the techniques that we've developed for use in infants. Same type of an approach to the examination process, depending upon objective techniques of examination. And I talked about that previously. So in this particular case, this child has very high refractive error. This child has developed an intermittent left esotropia. Why? Because that's the eye with the higher refractive error. When the child makes an effort to accommodate the 7 diopters, this child can't do it because one of the other manifestations of Down syndrome is impaired accommodation function. This is something we're now very aware of. There have been some wonderful studies that have looked at the accommodator process in individuals with Down syndrome, and we find that it is very impaired in almost all cases. So just as an aside, in an adult, they're going to probably need reading correction, near correction, at an earlier age than would be typical for others. Because of the impairment of accommodation, if you provide correction, particularly for a high hyperopia like this, you may at some point may need to add a bifocal correction, which can be difficult for the child to be able to adapt to. So these are all things that you need to keep in mind. The important point here that I want to make is that Down syndrome is a syndrome. And a syndrome means there are a number of related signs and symptoms that go along with the underlying diagnosis. Just in terms of vision, there are cataracts, there are accommodator problems, there are high refractive errors, there are surface issues in and around the eyes, the cornea specifically. All of these things need to be taken into account. So when you see a patient with Down syndrome, you need to be thinking more broadly than just the issues that are in front of you in the patient in terms of refractive error. It's more complicated than that. Now, I want to mention one other thing as I talk about this case of Down syndrome. In many ways, pretty closely related, but obviously completely different, is the issue of a child with cerebral palsy. So obviously, Down syndrome, cerebral palsy, totally different, have nothing to do with each other, except for the reality that many of the problems in the visual system are similar. Individuals with cerebral palsy, and I'm not going to go into the details of CP, it's a very complex topic, potentially a discussion point for another talk. These individuals have impaired neurological processes. The entire neurological system is abnormal. It's not just motor function that's abnormal. Pretty much everything else related to the nervous system is abnormal. It's a nice way of saying that strabismus is extremely common. High refractive error, coincidentally, is also very common. These individuals all need to be examined at a young age. Blanket statement here. Any child with Down syndrome, any child with cerebral palsy, any child with mental retardation or other developmental abnormalities that are evident in early childhood, every single one of those children need to have a comprehensive eye examination done as early as possible. And the reason is simple. We do vision screening in general to identify a high-risk population. Children with Down syndrome, children with cerebral palsy, children with developmental abnormalities all have high risk attached to those conditions. From a visual perspective, every one of those children are at high risk. Beyond that, there's another issue that's even more important, because their educational progress is often going to be compromised by their underlying conditions. The visual system becomes even more important to them as part of their education. Any deficits in any of the sensory modalities can have a dramatic negative impact upon that child's ability to learn. So from a health perspective, these children need to have vision care at a very young age. From an educational perspective, these children need to have vision care at a very young age to fine-tune their visual systems to give them the best opportunity of succeeding in their future education. So a child with cerebral palsy has a near certainty of developing strabismus. Yeah, there probably are some kids that don't develop strabismus, but make an assumption that they will. What happens very often is that a child with cerebral palsy in the first year of life will develop esotropia. I've seen too many ophthalmic surgeons go ahead and do surgery on these kids at a young age with the belief that that is critical to their visual development. That is frankly a mistake. The reason is that the fragility of the oculomotor system invariably converts, as part of a natural history, that esotropia present early on with an exotropia that develops a little bit later. That exotropia is very common and is by far the most common finding in terms of ocular motility and ocular position in older kids. Bottom line, most of these kids will have, at the very least, intermittent XTs or constant XTs at later ages. Surgery may be indicated at that point to straighten the eyes, and that's something that might be considered, but doing early strabismus surgery should absolutely not happen. In addition, as I said, refractive correction is very common. There is often nystagmus in these kids, both with Down syndrome and cerebral palsy. Again, another manifestation of problems with the neuromuscular system in general and the neuromotor system in the eye specifically. All right. Another situation, I touched upon this last time. I think I did talk about this case. 6-year-old child failed a school screening. Child comes in for an examination, and what do you find? A huge amount of astigmatism. I mentioned that very high astigmatism has a strong ethnic basis. There are some ethnic groups, some groups within individual countries that have much higher amounts, frequencies of astigmatism than others. In the United States, we have our Native American populations have, in some cases, astronomical amounts of astigmatism. And that's also true with a lot of individuals from Latin America, South and Central America, who have a lot of Native American parentage. As a result of that same Native American genetic predispositions, they tend to have very high astigmatism. And we see that very commonly in the United States. In Boston, we have a very large population of people who have immigrated over the years from Central America. And we see incredible amounts of astigmatism, 5, 6, 7, 8 diopters in some cases. These children come in with reduced visual acuity. They may be picked up on a screening. The parents often have the same problem. So hopefully, if we've done a good job of educating parents as to their high astigmatism and saying to them that your child has got a very strong likelihood of having a similar problem, so you should see your child at a very young age. If so, we can prevent some of the adverse effects of that high astigmatism in the form of meridional amblyopia. Very simply, it means that in this case, in one meridian, there's minimal refractive error. 90 degrees away, there's maximal refractive error. So they have an amblyopia that is greatest in magnitude along a certain meridional vector. These individuals can experience sort of interesting, call it unusual findings on visual acuity testing. So if you have the shape of letters that correlate with the axis of maximal amblyopia, so in this case here, axis 65, a letter V, shaped like that. So one arm of that V may be completely out of focus. The child may not recognize that as being the letter that it is. On the left eye, axis 105. So in this case, a letter T, the vertical arm may be blurred, the horizontal arm may be clear. The child may not recognize the letter T. The child may see a letter I. So these kids may very well have difficulty developing reading skills because they cannot see the letters for what they actually are. The corrections to provide a full correction of the astigmatism. And as I've talked about, focused image 360, both eyes simultaneously. I would provide full astigmatic correction with the exact axis I find by my retinoscopy. Now, how effectively can you do a subjective refraction of a child in this situation? And the answer is you can't. You can't because this child cannot discriminate letters well enough to be able to give good feedback as to what their visual acuity is and what changes in a Jackson cross cylinder by 15 degrees are going to provide. You've got to go by your objective findings. So trying to do subjective testing along the lines of what we're all taught is a guarantee that you're going to end up with inaccuracy. They're simply not going to be able to provide the information you need to come up with the proper refraction. So bottom line, got to do retinoscopy. In this case, you provide that correction, you put it on. Now you may or may not give the full plus. I actually probably would drop the plus 75 altogether, probably just plain O minus 575. Have the child come back in a month or so. Do your best with quantitative assessment of visual acuity and just continue along those lines. Is there any patching to be done? Well, in this situation, we got a measure of one line difference in acuity. Does that make sense? Well, you could argue that there's a diopter difference in the amount of astigmatism. So yeah, maybe it's real, and it might be, but I wouldn't go by that. I wouldn't say definitively that there is a relative difference in visual acuity between eyes. There's a suggestion of that. Only over a period of time are you going to know. In any event, if there's only a small difference in visual acuity on follow-up examinations even 6 months later, are you going to do any patching for that? Probably not. What I would do would be to very, very carefully refract again. It may be that you are off the first time. Is it possible for your retinoscopy to be off a little bit in terms of axis or magnitude in this situation? Absolutely. These are difficult. So you want to recheck your refraction on each visit. And if it's only off by a tiny bit, you probably don't need to do anything now. You can wait until the glasses get lost or broken, which will happen at some point. If it's off by more than a little bit, then you probably want to do something right away. So I want to stop here for a moment. And for the first 3 cases that I presented, I want to ask the audience, do you have any questions at this point that you would like to ask me? Give people a minute to be able to formulate questions and be able to pass them on to our moderator. I'm also looking at the chat box, so if anybody comes up with anything.
Okay, so please put up any of comments, questions onto the chat box.
And if there isn't, we can move on, but I'll give it another minute.
Okay.
All right, so I guess nothing yet. Let me move on to the next case. All right, 4-year-old child having some difficulty seeing while playing and watching TV. Parent brings the child in, visual acuity significantly reduced in both eyes. Your cycloplegic refraction is very high plus with quite a bit of SIL. And I might add that not only was the cycloplegic retinoscopy what it shows on the screen, in all likelihood, the dry retinoscopy is going to be almost identical. I talked about this case before, but I thought it was worth emphasizing it again today. So this is a situation where this child has what we call isoametropic amblyopia, super high plus. This child has been literally out of focus from the day of birth on. This refractive error was present at birth. In all likelihood, this child has very small eyes. You might see a visible iris diameter that is smaller than average. You may not. But if you were to do ultrasound, looking at the size of the eye, you would find that the posterior segment of the eye is much shorter than normal. We did a study some long time ago on kids like this, and we found that the anterior segment from the cornea to the front of the crystalline lens is relatively normal in configuration. Nice way of saying corneal curvature is within the normal range. It's not absurdly steep, as you might guess, with a small eye. The anterior chamber is relatively normal in depth, but from the posterior crystalline lens out to the sclera, it's much shorter. It may be 3, 4, 5, 6 millimeters short. And that's why you've got the hyperopia. So was there a developmental abnormality in the development of the eye? Maybe. We don't know that yet, but it's a hypothesis. What we do know is that because this eye is so wildly out of focus, there never was the development of normal vision. And in many ways, the kind of amblyopia that you have here, which is bilateral and usually very symmetric, takes on a lot of the characteristics of deprivation amblyopia and less of the characteristics of refractive amblyopia. Recent years, we're beginning to learn more about the neurobiology of amblyopia, and we are learning more about the structure of the ocular dominance columns from the lateral geniculate all the way to the visual cortex, a lot of the microstructure related to that. And we now recognize that there are, in fact, differences in this form of refractive amblyopia from the other forms of refractive amblyopia. And there are characteristics that are much closer to deprivation. That also tells us that the treatment of this condition is also fairly similar to deprivation. You put the correction on, you will see over a long period of time, slow, gradual improvements in visual acuity. Even over a 20-year period of time, you may never reach normal visual acuity. There may very likely still be some deficit. 1, 2, 3 lines of deficit of visual acuity. The important thing here is to recognize the situation, to not be afraid to provide a relatively full level of correction. And I say relatively full because there's one other problem that comes about as a result of this scenario, and that is bad accommodation. The accommodative system has never developed because there's been no need for this child to ever utilize accommodation. So unlike 99.9% of other people, they begin accommodating during infancy. They begin to develop fine-tuning of accommodative systems. These kids don't. So in a sense, it's like never developing the ability of walking. You can't expect that you're going to suddenly be able to walk normally if you've gone a long period of time without being able to do that because of some physical problem that might have existed in the child's early growth and development. These kids can't accommodate. So what happens is they try to look at something close up and they can't. So notice that near exophoria present. That's a hallmark of this situation. You will almost always find exophoria, invariably at near, but sometimes also at distance. Not usually exotropia, but exophoria. And the reason is that there's a lack of accommodation. It's not happening. So these kids may need, for school use, when they get to a point where they really have to depend a lot on the visual system for developing reading skills, they may need a near add way before you would ordinarily even contemplate such a thing. So what I do is I also want to begin exercising the accommodative system. So I would provide all but about a diopter and a half of the hyperopia. So instead of the 10, I give an 8.5 along with the SIL. Give an 8.5 on both eyes along with 275 SIL at 90. And I do that because I want to begin having that child begin utilizing accommodation. Now, if I cut the plus by too much, if I only gave 5 diopters, now there may be a rationale for this child to begin trying to utilize their accommodative system to clear up the 5 diopters of optical blur that we've left on the table. So if we give 5 and there's really 10 there, that means there's 5 left. Can the child now attempt to accommodate 5 diopters? Or if I gave 7.5 diopters, for example, the child was attempting to accommodate 2.5 diopters, you may actually create a scenario where you cause accommodative esotropia to occur superimposed over the underlying problem of the isoametropic amblyopia. So it means you got to be thinking through the situation. You've got to understand about the accommodative dysfunction that occurs in these cases. You've got to understand that you want to put a focused image on the retina. You want to try to begin stimulating accommodation. So cut the plus a little bit. And what you typically see is an improvement in visual acuity of a line every 6 months, maybe a little faster, maybe a little slower. Some cases, maybe a line a year. But you often will get improvements in visual acuity at a steady pace over a long period of time. And it's very satisfying to watch that. And as that's happening, you need to take into account the reading demands and the educational demands and consider when and if you need to provide a near correction. I'm going to stop there for a second. And there was a question on the chat line. In case 3, how binocular bounds plays a role with such high sill. All right, so let me go back to that. There's the high sill, there's the case, and how binocular balance plays a role. Well, in this situation, there is an assumption that there is no strabismus. There is an assumption that there is no amblyopia relative of one eye to the other. So the binocularity is still intact, although it is not normal. So the binocular system is not fully developed because the visual acuity is not fully developed, but there's not a breakdown. So I think the short answer to it is that binocular balance plays a role because you don't want to do anything to disrupt it. Now, I don't think anybody is going to suggest that you would give an unequal amount of plus in the situation where you find symmetry. In the case of the astigmatism, where there is somewhat of a difference, that may be what the individual was referring to about the binocular balance. But again, from my perspective, putting a focused image on the retina takes care of that problem. All right, so let me continue.
Sorry, Prof. There's one more question related to this case 3. I think you probably would have mentioned about the 0.75 sphere. And would you be prescribing or would you be not prescribing, and why?
Okay, that's a good question. I think I did mention that there would be, I think, different perspectives on the part of even experienced people about whether to prescribe it or not. I probably would not prescribe it. I probably would just give a plano. It's an insignificant amount. It's not really so relevant rather, to the astigmatism issue and the meridional amblyopia issue. I don't think that less than a diopter of hyperopia is really going to make any difference in this situation. The other point to keep in mind is that because the visual acuity is reduced as a result of the meridional amblyopia, the stimulus to accurately accommodate is also reduced. So it's a little bit like you got a pair of binoculars, you've got a blurred image, and to be able to fine-tune those binoculars, even with a blurred image because of, let's say, fog, just for argument's sake, within the field of view, you're just not going to be able to fine-tune things as accurately. And in a similar way, the ability of this individual to fine-tune things with accommodation is going to be limited because of the reduction in visual acuity. So that would be my take on it. Personally, I don't think I'd bother with the low hyperopia. Other people may argue that they would. I don't think that we have any really good answer as to what to do. And maybe this is now a good time for me to say one other thing, a little bit tangential. And that is you've heard me say before that I am a really strong proponent of what I view as evidence-based medicine, evidence-based optometry. I believe that pretty much everything we do should be based as much as possible on what the evidence tells us. And the evidence in general are good, well-designed, controlled studies, and typically multiple studies that arrive at a similar perspective. Do we have that perspective? Do we have that evidence basis when it comes to prescribing for refractive correction? The answer is no, we do not. I have had the experience, actually. I was the chief author about 15 years ago, I guess, of the American Optometric Association guidelines on the care of the patient with hyperopia. So I wrote one of the clinical practice guidelines along with a group of other people who were involved in it. And we looked extensively at the literature basis at that point for hyperopia. And to be honest, there was virtually none. There have been some efforts since that time to do some large controlled studies. Some of my colleagues in the VIP study have been involved in one of the Pediatric studies that attempted to do a large-scale controlled clinical trial on the correction of hyperopia in young kids. And frankly, that study failed because there was a lack of agreement on how to structure it. And there was also great difficulty in recruitment. So the bottom line is that subsequent efforts to arrive at an evidence basis for correcting hyperopia have simply failed. I don't know if we'll ever be able to do that. There are a lot of impediments to that. So bottom line, the evidence basis doesn't exist. So what we're left with then are what we call consensus guidelines. And what that means, like the hyperopia guidelines that I helped to write, is you get a group of experts together, put them in a locked room, and make them come up with what they believe is the right approach. Let them argue it out. Let them attack it from a number of different perspectives, try to find where the middle ground is, and then propose that to a larger group, have them take apart the recommendations, try to find holes in it, and then if it still survives, you publish it. And that's pretty much what we have. So we don't have good evidence basis to this. Nonetheless, the guidelines that have been written are guidelines that are now routinely followed. So for example, when I say focused image 360, both eyes simultaneously, that isn't only coming from me. That's really coming from a number of the other guidelines that have been written both within ophthalmology and within optometry and within combined efforts. So the Pediatric studies, the ATS studies, amblyopia treatment studies, utilized those guidelines in the recommendations for everyone involved in those studies doing research projects on treatment of amblyopia that are within the constellation of the ATS studies. That's in effect where this comes from. That is the recommendation: provide full astigmatic correction, provide a certain amount of partial or complete correction for hyperopia in the case of accommodative esotropia. So they're not based on solid evidence, they're based on consensus guidelines, but they continue to hold up with a lot of introspection and a lot of discussion. And no doubt there will be changes and modifications over time as we learn more and more people enter into the discussion. But at least for now, that's kind of what the recommendations are. So, all right, let's go on. So that's what I would do here. I would give the correction. I would see the patient back periodically. I would make minor adjustments if necessary in the distance correction. You are not likely to find changes in the degree of hyperopia in this situation. And the reason for that is that there is essentially no latent hyperopia present in these cases of isoametropic amblyopia. There just isn't. All that hyperopia that's there is evident. It's all out there. It's all manifest, is for the proper word to use. It is not latent. So you're not likely to find changes. These individuals, in my experience, don't go through emmetropization. I would say that emmetropization, to use a one-word phrase, is broken. Something impaired it right from the beginning during fetal development, no doubt, that created that +10 on day one, and it's not likely to change. In my experience of seeing a lot of these kids over a long period of time, I have been amazed at how little change over literally decades I've seen in patients. I've also been impressed with how the visual acuity does improve over a very long period of time. You need patience. You need to be able to explain to the parents it's going to be a long process. The child is probably going to end up being fine. There may be some school-related issues that you're going to have to deal with along the way. Maybe they'll need large print books or things of that sort, better lighting, more time to take tests, mitigations, as we call it in the US, for educational processing. But in general, these kids end up doing fine. All right, let's change the scenario slightly. Keep things very similar, except change the sign from a +10 to a -10. So here's a child that was noted by the parents to have difficulty seeing, playing, watching TV, comes in for an exam. Visual acuity is really bad, maybe barely measurable, maybe not measurable at all. Maybe the kid doesn't even make an effort to provide quantitative visual acuity assessment. But in all likelihood, you're going to be able to see this kid as he walks from the waiting room into your exam room, having some difficulty with the environment. Maybe not, but probably yes. Your exam, high myopia, both eyes, very high. What's going on here? Well, this is a situation we've all seen. We've all seen individuals that have extreme myopia from the beginning. In many cases, like this child, it may not be discovered until some point later. But if you got your hands on this kid on day one, you would almost certainly find this. In my view, in my experience, a lot of the talk that we find in the literature about progressive extreme myopia is just simply not true. I have not, in my own experience, seen a whole lot of this wildly progressive myopia where you see maybe nothing. You have no reason to suspect at a very young age. You see a child at age 2 with a lot. You see a child at age 3 with a lot more. You see a child at age 7 with a whole lot more, getting up to a -20 or something like that. I just have not seen very many of those. I know they're out there. My experience tells me that many of those kids have other stuff going on. The other stuff going on breaks down into 2 major categories. It breaks down into stuff that is caused by the environment, most commonly retinopathy of prematurity associated with very high myopia. You see that. Is that progressive? In my experience, no, not really. What you see in infancy as a result of the ROP is high or very high or maybe extremely high myopia in one or both eyes. Does it change? My experience, not so much. What does change in a child, a very young child, where you are having difficulty doing retinoscopy? What changes is your ability to get an accurate reading. Now, with all my experience, I have no difficulty at all saying I'm imperfect. My ability to do a perfect retinoscopy in every patient every time is, of course, not there. I can't do that. I make mistakes. I underestimate. I see things that aren't really there. That happens all the time. Somebody who's a student, I suspect it probably happens more often. But it happens to all of us. None of us are perfect in doing this. We have kids, young ones, that are difficult to examine. They're squirmy, they're moving around, you're holding a high-powered lens in front of them with the kid flailing all over the place. It's tough. So you're going to be inaccurate, you're going to make mistakes, you're going to have differences from one time to another. So bottom line, I don't think that there's a whole lot of the explosive progressive myopes that I sometimes hear about. They do exist, there are some. This is a case, let's argue, it's probably been there, probably hasn't changed a whole lot. My ability to be able to pinpoint the exact numbers get better with time. The child's experience with being refracted, with sitting still for an exam gets better, become more cooperative. I'm already starting off with a good estimate of where things should begin, so maybe I could be faster and quicker and better. in any event, this is what you get. So what do you think about in a situation like this? Well, there are a number of issues that are pertinent. Maybe there's amblyopia here. Do we know that? We don't. There's certainly enough myopia that there can be amblyopia on top of the uncorrected refractive error. But of course, where you're starting from is the uncorrected refractive error. What do? The best you can do is put your best refractive correction on and see what happens. In all likelihood, this kid is going to wear these glasses incredibly well. This kid's going to put these glasses on for the first time, and he's not going to take them off ever again. So you're not going to have compliance issues with this kid. Vision probably will get better. Maybe it'll get better instantly. Maybe it won't. 3-year-old kid, again, your ability to actually measure visual acuity is impaired at best. So what I would do is I go by what I see, I put the correction on, I leave it there. The other issue is there some syndrome that is part and parcel of this high myopia? There are literally dozens of syndromes. In no exact order, Marfan's, homocystinuria, Stickler's. I can go on for hours with a whole variety of syndromes where high myopia, fetal alcohol syndrome, is part and parcel of the underlying condition. It is really important to be communicating with the child's pediatrician about, is there anything else going on systemically with this child's health and development that is potentially related to one of the syndromes. And I can't tell you how many times that my interest in the child's refractive condition then related back to the pediatrician helped to identify underlying conditions the child had that the pediatrician was not necessarily aware of or paying attention to. And only when he had the additional information about the potential for there to be a relationship with a vision problem of importance and a syndrome that might have a whole variety of manifestations in a child's general health, where the proper diagnosis was made. So you have that. You got ROP, you got the syndromes, but then you got the other. And the other is bad retinas. When I say bad retinas, what I mean are things like posterior staphylomas, retinal conditions of all sorts. There are syndromes that are ocular in nature and don't have systemic manifestations. And you could think of cone dystrophies, and you could think of albinism. You can think of a whole bunch of different conditions that are primary eye related that also have a breakdown in emmetropization right from the get-go. And don't forget that somebody with a very high refractive error has got a breakdown in emmetropization. So I provide the correction. I want to get as good a look at the retina as I possibly can. One of the great tools that we have available nowadays, many of us have access to, is OCT. OCT is wonderful because you now have an objective technique if you can get the measurement on the kid. And that, of course, is not always easy. But if you can get the measurement, you know what the status of the retina is, and particularly the macular area. You know if it's an intact macula, an intact fovea. And that tells you everything you need to know about what's going on. So let me go back again to some of the questions that were raised before. I'm now gazing at the chat. Let's see, Maria Concepcion, case 4 may be due to fetal developmental problems in utero for having short eye and thus have something to do with nutritional aspects of the mother and child during pregnancy with a question mark. The answer is yes, absolutely, positively. Now, it could be nutritional, it could be a disease entity that the mother had. Mother might have gotten any one of the infectious viral illnesses, God, rubella, cytomegalovirus, you go right down the list. Any of those things can also cause developmental abnormalities in the fetal development of the eye. So yes, absolutely. And that's why it's obviously important to get the best history you possibly can and to get the information you can from the primary care providers that the parent and child have. So being able to discuss the case with the obstetrician to find out if there was anything going on during the mom's pregnancy, or the pediatrician to find out if there are any other health concerns, is really, really important. And I think that's a great point. Let's see, another one from Siddharth Motowala. Patient age 23 having refractive error of less dramatic astigmatism, the age of 23, never having been corrected. Okay, so let me just go back to that briefly. So let's say that the correction is, or rather the amount of astigmatism is now half of what you see on the screen. I think that's the basic question. What would I do in a 23-year-old? Well, I don't see 23-year-olds, so I don't really know. I only see kids. So if that was the case, what would I do? Would I be more sensitive to the issue of adaptation to the amount of astigmatism? The answer is, yeah, I guess I would be. So that would be a situation where the adaptability of a 23-year-old is nowhere as good as the adaptability of a 6-year-old. 6-year-old, in my experience, is going to be able to put those glasses on and after a few days tolerate them. 23-year-old, I don't have a lot of direct experience, but I'll accept the hypothesis that less adaptable. And in a situation like that, would I prescribe maybe half or 2/3 of the correction? Yeah, I think so. I think that's an entirely reasonable thing to do. So I guess I agree with that. I would do that. All right, let me go on. In many ways, this is going to be, I think, the most interesting cases of all, kind of my favorites, if you will. All right, 4-month-old infant comes in. Reason parents bring a child in is there's lots of nystagmus. Have any of you seen infants with nystagmus? I guess those of you who see young kids, you certainly have. And I will tell you something, again, based on my experience and based on the experience of many others in the United States, and my experience as well in a number of other countries around the world in more recent years. The single most likely cause of early onset nystagmus in otherwise healthy, underlined, otherwise healthy, again, underlined, otherwise healthy infants is albinism, and in particular, ocular albinism. Let me say that again. In my experience, ocular albinism is the single most common cause of nystagmus in otherwise healthy infants and young children. It is also, in my experience, the most commonly misdiagnosed condition I have probably ever seen in my life. I have seen more cases that have been called all kinds of other things when in fact they were ocular albinism. I'm going to briefly touch on this particular one on the screen, and then I'm going to talk about an older kid, and then I'm going to talk more generally about ocular albinism, because I think it's really interesting. And in many ways, it is, for me, a synthesis of all the things that we as optometrists need to be thinking about beyond the obvious, apparent refractive problems that are in front of us. The separation that I believe is between our profession of optometry and technicians, ophthalmic technicians or ophthalmic nurses, is our understanding and our education in many of the other aspects of children, of healthcare, of the visual care system, the vision system rather. And that is, we need to know something. So we've already talked about the case before. We need to know something about embryology. We need to know something about histology. We need to know something about general medicine, general pediatrics. We need to know a whole lot of other things beyond what a technician can be taught and a technician can do effectively. I know many ophthalmic techs and ophthalmic nurses, and so do you, who are incredibly good at doing refractions, at doing testing. They can do the procedures really well. They may have done those procedures hundreds or thousands of times. When you do any procedure a whole lot, you get good at it. Or hopefully you do something else instead. But presumably you get good at it. But it doesn't mean that you know why you're doing it. It doesn't mean that you understand the reasons why the situation is the way it is. Ocular albinism, in many ways, summarizes a whole lot of the necessity for us to understand these aspects of the visual system, about how the visual system operates, how it's constructed, what the anatomy and the physiology and development is. So this is a typical presentation. Baby comes in with nystagmus, and the baby may have seen others before and come up with all kinds of diagnoses, often ominous diagnoses, because the assumption usually is nystagmus equals brain tumor. Nystagmus equals a bad derangement, dysfunction of the nervous system. That's often the thing that people jump at. Very often people jump at the worst case scenarios. You ever heard the term, we go after the zebras? Anybody know what that means? The zebras typically mean in the US, we're thinking about the rare, serious, unusual conditions because they're interesting, they're sexy, they're unusual. We get excited about those things. But in fact, most things are not like that. Most things have a more simple rationale to it. And yeah, there are some kids, there are some 4-month-olds with glioblastomas and neuroblastomas and horrible neurological or oncological diseases. But fortunately, they're much rarer. Ocular albinism, on the other hand, is pretty damn common. I cannot tell you how many I have seen in my time. Typical presentation, parent brings the baby in. The eyes are moving all over the place. There is no null point. You look at the eyes, you look at the pigmentation, and particularly for many of you in Asian countries, your population is darkly pigmented. The next case I'm gonna show is an immigrant from Africa, a very darkly pigmented individual. People know oculocutaneous albinism. Everybody has an image of that in their mind. You can spot an oculocutaneous albino on the street from 100 meters away. You know what they look like. You know there's an absence of pigmentation. It's an adult that got dark sunglasses on. You know this. You've seen those individuals. Long before you got into optometry, you knew who those people were. Anybody can make that diagnosis from 100 meters away, literally. Ocular albinism, on the other hand, is probably 10 times more common and a completely non-apparent diagnosis. There's nothing you can tell. The pigmentation in general is normal. So whatever the pigmentation is of the family is what you're going to find in the child. Nothing different. Dark eyes. Do albinos have dark eyes? No, they all have pink eyes, right? No, they don't. They have high refractive errors. They have all kinds of stuff going on. So that's a typical scenario in an infant. They come in, what brings them in is the nystagmus. And the concern on the part of the pediatrician or the family is there's something ugly going on. There's something really horrible going on. Good news is it's not as bad as all that. Things will actually get a little bit better over time. So here's the situation. It's an older kid. This is a real patient I had. This kid came out of a refugee camp in Africa. Never had one iota of healthcare in his life. Got on an airplane out of Africa, landed in Boston. 2 days later, was seen at our hospital, Children's Hospital, for a head to tail examination, healthcare examination, which is what we typically do. So we give him a thorough examination, looking for anything and everything. Run him through every clinic in the building. My turn to see the kid. Kid's got nystagmus, history of poor vision. Kid had great difficulty learning to read or do things. Do my exam, I find very high hyperopia and astigmatism, poor vision, maybe worse in the left eye, but it's a one-line difference. Is a one-line difference meaningful? I don't know. Not at this point, not really meaningful. There's a variable left esotropia. Does that make it more meaningful? Yeah, I guess it does. It says probably there's superimposed over all this strabismus and amblyopia, other stuff going on. There's really no null point, maybe a little bit in left gaze, but maybe I'm just imagining that. So how do I know what the diagnosis is? This is a darkly pigmented individual, okay? So irises are really dark, the complexion's really dark. This is not the oculocutaneous albino. The single best test that doesn't work every single time, but it works a lot, is take the patient into a black room, no light source whatsoever, not even a pilot light in the room. Get it dark. Take your transilluminator, and for those who have no idea what a transilluminator is, when you bought your first diagnostic kit from Welsh Allen or Keeler or Heine or whoever, hopefully there was the little flashlight thing, the little silver bent light that's called a transilluminator. And what you used it for was a muscle light. You used it for EOMs. You used it for doing pupil responses. But actually, it's called a transilluminator. So you kind of maybe thought for a moment, what's transillumination? Well, maybe you heard about it. Maybe somebody mentioned it to you, but you probably never used it for that purpose. The transilluminator simply is a very bright, concentrated light source. And what you do, if you can see me on the screen, is you take it in a black room. You don't put it on the eye. You put it near the eye, right through the skin even. You can put it right on the sclera if you want, but you don't have to. Put it on the eyelid. The light goes through the skin of the lid, goes through the meat of the eyelid, goes through the sclera, goes into the inside of the eye. It reflects all over the place, and then it is transilluminated. It is illuminated through the iris. The level of iris pigmentation, the level of the iris stroma is so thin that the light that is reflecting in the inside of the eye from the lamina corbosa, from the internal limiting membrane, is basically being reflected through the iris. And it glows. It actually glows. It lights up. You can see it. The first time you see it, you kind of go, ooh and ah. And I had this experience when I was in Vietnam a couple of years ago and taking a bunch of the ophthalmologists and the optometry students into a black room with one of the first kids I saw with what I knew to be ocular albinism right from the get-go. And I talked about transillumination, and everybody remembered that they heard about it from somewhere, and everybody kind of remembered they had that light somewhere in their kit. And all of a sudden, there it was. It lit up. You then take that same light, and for one of the other people in the room that doesn't have the condition, shine the light in the same way. The light doesn't come through. So you have your control of a normal, you have your individual with the ocular albinism, it transilluminates, you've made your diagnosis. There it is. It is done. You then can look in the eye with an ophthalmoscope, direct or better, a binocular indirect ophthalmoscope, and what you typically see, even in this dark African kid, is you see a very lightly pigmented fundus. You cannot see a foveal reflex. You see a macular area, or at least kind of where the macular area should be, that either has minimal pigmentation or maybe no pigmentation at all. And actually, in some cases, actually looks like it has less pigmentation. The fundus pattern is this tigroid fundus pattern, which is really the choroid, the choroidal pigmentation, such as it is coming through. So you've got a grossly deficient eyeball in terms of pigmentation. Your diagnosis is made. You've got it. Lack of a fovea, iris transillumination, high refractive error, nystagmus, iris transillumination, other features we'll talk about, make the diagnosis. So that was a diagnosis. Now, you could argue Was there amblyopia in the left eye? Maybe, probably. I don't know for sure, but I'll make an assumption that, yeah, probably there is amblyopia. I'll cut the plus, cut it by diopter and a half, reasonable. Now, what effect will this have on the child? Well, first of all, visual acuity, at least for an instant, each cycle of the nystagmus will be better. But remember, a spectacle lens has an optical center. When the eye is at that instant aligned with the optical center of the spectacle lens, you have good optics. But only for a very small percentage of the time are the optics of the lens and the optics of the eye aligned. The vast majority of the time, you can work this out mathematically, but you're probably talking 90, 95% of the time, they're not aligned, they're not optimal, they are by definition suboptimal. So the visual acuity is still not as good as it might be because you are not necessarily getting that focused image on the retina 360 simultaneously. You will remember when all the other discussions you've had about myopia progression and a lot of the ideas about using contact lenses or spectacles that have asphericity to them that might be beneficial. We all know now intimately that the eye doesn't have the same refractive power from one end of the retina to the other. It is different. There's oblate and prolate shapes. I'm not going to get into that, but there are differences in the power. So you don't have that focused image. So it'll lead to a discussion in a minute about what option might be. But the fact that you now have at least some of the time a good correction and most of the time at least a half decent correction means now you're going to get better visual acuity. Having better visual acuity has the potential of decreasing the nystagmus. Better optics may decrease the nystagmus. Decreased nystagmus may by itself improve visual acuity. So you have less movement, you have less disruption of the image, you have a better opportunity for the processing areas of the visual cortex to utilize that image coming from the eye in a more effective manner. You might get better vision as a result of that. Having improved vision may, in a feedback loop, cut down the nystagmus somewhat. So simply providing optimal refractive correction can dampen nystagmus, can improve visual acuity, which then can lead into a feedback mechanism, feedback loop of further improving visual acuity over a period of time. If in fact there is an amblyopia component to it, it will also tend to get a little bit better in the same way that we talk about first step in treating any kind of refractive amblyopia is put the glasses on. If there was a refractive amblyopia in this situation, putting the glasses on is step one. Are we ever going to think about putting a patch on? No. Why? You will remember, if you want to get good visual acuity, let's go back. So we got to measure visual acuity here. How did I do that? Did I have the kid put a cover in front of his left eye, a hand or a patch to get the visual acuity of the right eye? No, if I did that, I would be introducing a component of latent nystagmus. You occlude an eye, you get an occlusion nystagmus that increases the amount of nystagmus, decreases the visual acuity. In other words, you patch an eye, you make the visual acuity worse than it might otherwise be. How do you get a relatively monocular level of visual acuity? Put a high plus lens over that correction. So over that 950, put another 5 diopters, or 6 diopters of correction. Put a 15 diopter lens in front of that eye instead. You're blurring the eye further, but you're not occluding it. That's critical. Anytime you have nystagmus, do not occlude the eye. Use a high plus lens as a substitute for occlusion to get a monocular reading. All right, so we put the glasses on, and over time, hopefully things get better. I want to pull back a little bit here, and I want to talk about a couple of things. I want to talk about the heterogeneity of ocular albinism. But before I do that, I want to talk about some of the reasons why the visual system is affected, or some of the ways the visual system is affected. So the problem with ocular albinism in the child starts out during earliest fetal development. What happens is that when the earliest stages of histology of fetal development are occurring in the eye and in the structures that ultimately become the various structures of the eye, there is a lack of macromelanosomes. What are macromelanosomes? Macromelanosomes are the cell structures that create pigment within the body, within, in this case, the eye. There is a defect in the metabolism that creates those macromelanosomes. And as a result, the pigment generating structures do not develop. It turns out, we now know, that in order to get normal development of the retina and the visual system, you need as a starting point that pigment being present in the right place, at the right time, of the right structure. In the absence of all of those factors being correct, as they are in normal individuals, without ocular albinism, there is an abnormality. That abnormality affects the structural development of the cones. They do not develop normally. They do not have the proper end of the photoreceptor. They do not elongate. They do not pack at the foveal area. The ganglion cell layer does not know to move away from the fovea and macular area. So the ganglion cells continue to overlie the critical structure of the central visual axis of the eye, the fovea and the macula. You have an impediment of quanta of light hitting these abnormally shaped and abnormally developed cones. So you have an impediment of quanta getting to the cones. You have an impediment of bad structure and lack of packing tightly of the cones in that position. You do not get a foveal pit developing. When the cells, the ganglion cells, grow back through the optic nerve head, through the chiasm, they do not differentiate properly. You get an over-decussation of nerve fibers at the chiasm. In other words, too many of the nerve fibers cross. You don't get a normal distribution of crossed and uncrossed fibers emanating through the visual processing areas. That disrupts the ocular dominance columns, the whole ability of gaining binocularity in the visual cortex is broken. It leads to all of the other manifestations that you have. You do not get normal binocularity in individuals with ocular albinism. You have a very high incidence of amblyopia. You have high incidence of strabismus. You have an improper packing of cones, so you don't get the density of the mosaic of the cones to give you the ability of getting high visual acuity. You don't get a foveal pit. You don't have the ganglion cells moving away. All of these things are messed up. It tells you all of the problems of a functional nature that occur. We now know that you need a proper foveal development in order to get proper emmetropization. Bad structure fovea, bad emmetropization, high refractive error as a result. All of the structural manifestations going right back to the structure of the pigment cells in the earliest development of the fetal eye lead to this entire cascade of structural and functional problems that occur in the visual system. Now, I love the example of ocular albinism. When I talk to my students at NECO, and in particular when I had the opportunity of lecturing to them on the first day of their experience at NECO during their introductory sessions, finding out about the school and the profession and all of that, I always gave that talk. because you take something as simple in the minds of most people as refractive error, and you relay it back to all of these areas of knowledge that we as optometrists need to understand and be able to utilize on a clinical basis. Is the difference between our profession and many of the other eye care professions that do not get all this background information. And to a degree, that includes ophthalmology, in my experience, in many places around the world. They don't get the why and the how of. So this is really important from my perspective in the educational process of optometry, to understand these interconnections and really to understand why at NECO in the US, we give a course in histology, we give a course in embryology. These are not popular subjects, believe me. This is not what people, optometry students, really want to hear. They need to understand why it's important. Okay, so now let me talk about a family that I had as part of my experience that really taught me a lot about albinism. So I got a call from a mom one day. She had a baby about 5 or 6 months of age who had already seen a well-known pediatric ophthalmologist in a neighboring city around Boston, and was told the diagnosis. Diagnosis was ocular albinism. Kid had nystagmus. That is what got the parents to bring the child in. Okay, child came in, got the diagnosis. The ophthalmologist did good examination and essentially told the mom, your kid's going to be blind throughout life. You better already get the kid set up with low vision stuff later on, and just be aware that this kid's going to be damaged, and get used to it, and there's nothing you can do about it. The mom was very angry at what she was being told, so she gave others a call. I got a call and said, would I be willing to see the kid? Yeah, sure, bring the kid in. Next week, child comes in, I do my exam. Sure enough, kid's got ocular albinism. I brought the family into a dark room, got my students around. We got out a bunch of transilluminators. We lit up everybody in the room. Everybody had a transilluminator stuck on their eyelid in a black room. And all my students did not transilluminate. I did not transilluminate. The father did not transilluminate. The mother transilluminated a little bit, and the baby a whole lot. Now, this family were from the Middle East. They were Lebanese, and they were very darkly pigmented. They almost looked as if they were, African American in complexion. They were very darkly pigmented. So their idea, again, of albinism is oculocutaneous, and that was the thing that really kind of upset them about this diagnosis they got from the ophthalmologist. He never explained the difference between the two. And he never explained to them that, yeah, you can be an albino just in the eye and not have all the other physical manifestations. But what was interesting was not the baby. What was interesting was the mother. The mother had a mild form. She had slightly decreased visual acuity, not enough that it was ever an issue. So afterwards we said, okay, let's try to understand family history. Anybody else in the family have any vision problems? And she said, well, no, not really, but my father was blind and my sister was blind. Oh, well, I guess those count as problems. Tell me about your father and your sister. The father turned out to be one of these amazing self-made kind of guys. He had been in a school for blind children long ago, and he had done well. He was a really smart kid who overcame all of his issues, and he ended up actually becoming part of the government of Massachusetts, became a state senator, and had been a state senator for a long time. Now, he always had important vision problems, and all of the ophthalmologists and optometrists in the state always used this guy as a way of trying to gain political influence, because he had a vision problem. He was really sensitive to the political issues between optometry and ophthalmology. He had been involved in the fights over all the drug legislation and all the other stuff. He was very knowledgeable, and he always tried to be very even-handed. So he was fair to both sides. but he was always involved in legislation in one way or another of expanding access for vision care. And he told a joke to me. He came in the following week, and I got a history from him. And he said in the last 20 years, every eye doctor of importance would always want to see him and diagnose the problem. He never had a good diagnosis. He had 100 different diagnoses, but he said he never got one that made any sense to him. So he said he went to the Mass Eye and Ear Infirmary, the big, glorious eye hospital at Harvard, very illustrious place, big building, many floors. He said depending on what floor of the elevator he got off, what clinic he went to, he would typically get that diagnosis. He'd get a diagnosis of glaucoma or retina this or retina that, depending on who he saw. And he said he never believed any of them because, number one, it made no difference to him. So he didn't know what his real problem was. Another one of his daughters, the sister of the mom who brought this baby in, also had vision problems from an early age. She also did fine. She went off to California, flew 3,000 miles, went to university out in California, saw eye doctors out there, and had been treated for 20 years for glaucoma. Somebody decided that she had glaucoma, and that's why she had a vision problem, obviously ignoring the fact that she had the vision problem from birth. But she saw somebody in California who must have been a glaucoma person, who obviously thought glaucoma was the problem. Anyhow, the grandfather came in, he transilluminated, it was clear he had ocular albinism. 2 weeks later, the sister flew in from California with records 3 inches thick, all the records from California. She was being treated for glaucoma, even though she never had elevated intraocular pressure. Her fields were complicated by the fact that she had nystagmus. So when they did Goldman fields on her, there were dropouts everywhere. Shocking, huh? She transilluminated. So we got everybody in the room together and again, showed them all off to our students. And all these darkly pigmented people all transilluminated. We then said, okay, is there anybody else in the more extended family? And as it turned out over the next year, I ended up seeing about 15 other people in this incredible extended family that all had ocular albinism. And the interesting thing is that the severity varied dramatically from one to another. That first mom had a trivial case of it with minimal deficits. Others were much more severely affected with much more reduced visual acuity, much more visual dysfunction. But the range was incredible. Now, at the time, as you may know, we have a lot of programs with China at NECO. And I had a student who was with me who had been an ophthalmologist in China and had actually specialized in ocular genetics. So she got incredibly excited and said, is it okay if I do a genetic tree of all of these individuals in this family? And the family agreed to it. They were thrilled. So we did this genetic tree, and it turned out that every single potential genetic etiology could be worked out. There were X-linked recessive, there were autosomal dominant, there were autosomal recessive. There were all kinds of different inheritance patterns that were within this one family. Why is that? I have no idea. But today, this goes back about 15, 20 years actually, this scenario. Today, we now understand that there are many, many genes that are associated with ocular albinism. It is extraordinarily complicated. It is not the fairly simple, limited number of patterns that had been imagined 20, 30 years ago in the old textbooks. It's vastly more complicated than that. So bottom line, it's very variable. It has its etiology in this situation. And it is, I think, for me, very interesting. Now, let me throw this in, contact lenses. So think about this for a second. You've got a group of people with very, very high refractive error. They've got big time nystagmus. Their eyes are bouncing back and forth like this at a rapid rate. They're looking through the optimal optics of the spectacle lens only a very small percentage of the time. Is there anything that we can do that could improve the optics of this situation? Well, obviously there is. It's called a contact lens. Now, in this situation here, this patient does not have ocular albinism. This patient has oculocutaneous albinism. And obviously you can see the picture on the right. The brow is lacking pigmentation. The lashes are lacking pigmentation. The iris is blue, lacking pigmentation. That's your classic OCA, oculocutaneous albino. In that situation, there is obviously advantage in reducing the amount of light getting to the eye. So utilizing an opaque contact lens with a clear pupil that also provides whatever high refractive correction might be necessary serves multiple purposes. And that makes great sense. But if you have the optics that are correcting the situation moving along with the eye, you've solved that problem. You've gone from only 5% of the time of optimal optics to virtually 95% of the time, or maybe even more than that. So it then becomes really a critical case of designing a good contact lens that's going to stay on the eye, that's going to provide the right optics, that's going to maybe require an astigmatic component to it. I mean, all the complexities that everybody out there right now who is knowledgeable about contact lenses probably sitting there thinking about. And I'm going to guess that for any of you who are contact lens specialists, you've already done this kind of stuff. You've already done these patients for these reasons. You already know about this. But I suspect many of you have not really thought about this. What I did for that baby, that first baby, the baby I described to you from the family, I put contact lens on that baby right from the get-go. Those parents were highly committed to doing anything and everything to maximize that child's ability to do well in school and in life. I put high plus toric lenses on that baby's eyes. Yeah, the eyes are small. We had to get custom-made lenses. It's complicated. It was expensive, all of that kind of stuff. But we did what we needed to do, and it benefited that kid. A year or two ago, my wife and I were invited to have dinner at that family's home. They live in an area of Massachusetts, maybe 75 miles away from Boston. And I was down there for a meeting and ran into them. They invited us to dinner. Well, the child was now graduated the Juilliard School of Music, if you ever heard of that, the most famous music school in New York City, was now an opera singer on a professional level. And he was my patient, so it gave me an enormous amount of joy and satisfaction to see that everything we did for that kid turned out to be of enormous benefit. And yeah, that kid was not going to be someone who was going to depend upon his visual system for the central part of his life. But he was able to work around that, and he was able to get out of his visual system what he needed to be able to read his music, to be able to be part of amazing performances and all of that. And I mean, as optometrists, that's what we're supposed to be doing. So I think I'm going to stop there. Lots of information. I could go on, as you could guess, for many hours. There are many more cases we can do, but there seems to be a number of chat comments about that, and I'll let Frank Rudin synthesize those for me to answer. So any questions about this case or any of the others, I look forward to answering for you.
Yes, Prof. Thank you so much. I think everybody is actually overwhelmed with the information what you have shared, and I think everybody is actually thanking you for the wonderful session already, because I think that it's a very overwhelming information we have gotten. One question which is here, which I can read, is in terms of ocular albinism, which you mentioned about doing the tests, the transillumination. What would be the reflex, what you would see on a Bruckner's test? Would it be similar or would it be equal?
Great question. Well, first of all, you've got the issue of the nystagmus. So you think about the normal Bruckner test depends upon the reflection of the light coming off either the macular area, in other words, more pigmented, or the not macular area, less pigmented. In this situation, the macular area has no pigmentation. So what you're getting is a rather diffuse, albeit much brighter than normal reflex in both eyes. So if you think about the reflex, you are still going to see crescents relating to refractive error. You're not going to see anything related to strabismus or media opacity, unless, of course, there is a media opacity. And in my experience, there's no higher incidence of congenital cataracts or early onset cataracts in these individuals. So no cataracts. So you're going to see a uniformly bright reflex that's going to be somewhat difficult to interpret because of the rapid movement of the eyes. I do use the Bruckner on these individuals because that's just part of my examination process. And I don't necessarily get a lot of new information out of it, but I find it interesting to view it. And I think the variability you'll get will depend upon the amount of pigmentation in the retina. And in the case of that child from Africa who had dark pigmentation, it was interesting because he had the kind of reflexes that you would think would be more present in somebody with very, very light pigmentation, blue eyes. So it's variable, it's very changeable, but it is not that predictive or that helpful in making any diagnosis.
Okay.
Actually, I should
And
mention one thing about the contact lenses here. And I said that absolutely there is huge amounts of photophobia in these individuals with oculocutaneous albinism. And of course, the question somebody I'm sure has asked or will ask or should ask is, how about ocular albinism? Are they photophobic? And the answer is, generally speaking, no, they're not. They may be a little bit, but they are certainly not dramatically photophobic. So is there an advantage in using a lens like this, a prosthetic lens that is light filtering with them? And the answer is probably not, although in selected individuals where photophobia is a huge problem, say the answer should obviously be, yeah, think about that. But in the vast majority of experiences that I've had, photophobia is almost surprisingly not an issue.
okay. And in terms of tinted lenses, any specific kind of tints? Somebody is asking about tinted lenses, and what do you prefer as a specific kind of tint?
Well, I think light filtering more than anything else. So I think if you're going to go to a tinted lens, I think you want dark with a clear pupil. So I think the clear pupil is important, but I think as much light filtering through the iris as you can get. And that, I assume, is going to depend upon the options available to you in your respective countries. These lenses are difficult to manufacture. They tend to be very, very, very expensive in the US, at least, and I'm sure in all of your countries. They're also hard to get. So, I mean, those are all factors, but I think more than anything, you're concerned about filtering the light. You know, the ability of using sunglasses inside is, you know, a bit of an issue for people. I mean, it has its downside to it. Outside, obviously, it's beneficial, but inside, you know, if you can filter out as much light as possible with a contact lens, you're really helping these people a lot. So I'll leave it at that. Color, I think, is less important. The answer may be related to some of the ideas about various tints being useful, maybe in autism or learning disabilities or conditions like that. I'm not sure about all of that. I tend to be skeptical myself, but I'm no expert in it, and I would leave that to others. So I don't have an opinion about that in that context.
Right. And the other question, which is about nystagmus and the use of RGP lenses or hard rigid gas permeable lenses, would that also be different in terms of management? What's your take on that?
I would think that you probably would need to be selling the lenses by a 6-pack or 12-pack because within the nystagmus, you tend to get lens ejection. That was my experience. I mean, when I started doing this 1,000 years ago, we only had hard lenses available, and we'd lose a lot of them. It was very frustrating. Obviously easier to get in, especially in a kid, than a big soft lens. But the problem I had was loss, stability, movement, lens dislocating away from where you want it to be, and then parents having the nightmare of recentering lenses 20 times a day. So I'm pretty convinced at this point now that we have so many options available with soft contact lenses, I think at least for most of us, that I think is a better option. Also in terms of for astigmatism, a hard RGP toric lens, dislocating, rotating, being ejected, the cost seems to me to be kind of a nightmare.
Yeah, but I think according to one of our attendee, he says that there were some of the patients who he fitted them with RGP lenses in terms of nystagmus, and the latency of nystagmus was manageable.
Yeah. So that's correct. There is some evidence to that effect. One of the things I did not mention is that as you put the optical correction on the eye, you improve the vision, you dampen the nystagmus. You improve the vision, you dampen the nystagmus. There's also another theory that the weight of the lens itself, in a sense, acts almost like an anchor and weighs down the movement of the lens. So there have been a number of papers that have been written about that have argued that. And I think there is some indication that that's true. But it would be true, I think, with both a hard lens and a soft lens. Soft lens is going to have to be pretty big, even on a young kid. You're probably talking, I don't know, 14, 15 millimeter lens to be stable. You're talking about, say, a high +8 power. So you're talking about, what, half a kilo of plastic sitting on the eye? That's going to be true with a hard lens or a soft lens. But I do think that that individual is correct in stating that the weight of the lens itself, perhaps or probably or hopefully, I don't know what the right word is, has some effect upon reducing the nystagmus, therefore improving visual acuity. You take all those factors together, in my experience, you can measure VA with glasses and in the same patient, put the contact lenses on, measure VA again 10 minutes later, and find a 2 or 3 or 4 line difference in visual acuity. I have found that myself. There have been papers written that have shown that to be true. So I don't think there is any question that the use of contact lenses is not just beneficial, but I think it's really beneficial. And I think it is really beneficial as young as possible. This is a situation where trying to convince a mom of an infant of the benefit on a long-term basis, I think is real. Because if you can improve visual acuity in the first year of life, you're doing that family a huge favor.
Yeah, that's right. I think I saw one case when, in terms of nystagmus, they did a reverse picky bag. They put a soft lens over an RGP to make sure that the RGP was stable. The only problem is the oxygen transmissibility and all those kind of things. So, yeah, I have seen 1 or 2 cases like that, which was managed earlier on. So I think we have covered.
Let me also say that oxygen permeability for babies seems to be far less than it is for older individuals. I had a lot of experience before in fitting contact lenses for babies with congenital cataracts. And I will tell you that we almost never ran into issues related to oxygen permeability or corneal hypoxia. So I am pretty sure that because babies have wet eyes, as long as you're not fitting extremely tight and allowing for some movement, and with nystagmus, presumably you're going to get a lot of movement of the lens. I think it's much less of an issue than it might be in many other situations.
Yeah, that's right. I think, we have taken up all the questions for today, I think, Prof. Thank you very much, Prof, again for giving us your time and all the information what you have shared with us today. It was really overwhelming, and I wish we can listen from you again in the nearby future. A lot of attendees want that too. So we'll have to plan up another session, Prof.
Happy to do so. I enjoy this.
Thank you. Thank you so much, Prof, from all the attendees as well as from the team OOLS. Again, we do have sessions planned up next week on the Saturday and the Sunday as usual on the weekend. Please stay tuned onto your email and your WhatsApp group. We will be, sending out the information shortly. Thank you very much, everyone, for attending today's session. Stay home, stay safe, and I'll see you all next week. Bye-bye.
Bye-bye. Thank you.
Thank you, Prof.